I'm Fiona Godlee, Editor-in-Chief of the BMJ, and I'm very delighted to be here with Robert Francis QC, who recently completed the second inquiry into the Mid-Staffordshire scandal in the UK. We're here at Quality Forum 2013 in London, and I'm here to ask Robert Francis, first of all, how are you? You must be rather exhausted after the round of interviews, of which this is just the next one.
Well, I think the first point to say is I'm relieved to have completed the inquiry, to got the report out there, and reassured to listen to people talking about it. And if a price to be paid for that is I have to be interviewed from time to time, well, so be it.
Very good. What would you say to people who haven't been following this as closely as some of us have, were the sort of 2 or 3 key points that you feel you'd like people to take away from the report that you wrote, if that's possible to say, given the size of it?
Well, I think the first point is that hospital services or medical services in general should never be complacent about the basic standards of care being provided to patients, and should never assume that such standards are being met, would be the first point. And the second point would be that in order to find out about that, really everyone should listen to patients and listen to their experiences, because it's from that hospital services will find out whether they're providing what patients want them to provide. And if they don't provide, if they fail to provide that, they do so at their peril, and indeed at the risk of harming their patients, which of course is the worst thing of all. Yes.
Now, this has taken up a large chunk of your recent life, and there were the 2 inquiries. I just wondered what you felt the second inquiry achieved or uncovered or was needed for over and above the first.
Well, the first inquiry confirmed what was already known, but confirmed through hearing patients that the standard of care that had been suffered by them was absolutely appalling in many cases. And what it brought to light was a question not only of how it was that a hospital board, people who worked there, could have allowed that to happen, but also why it was that the wider system, where we in this country have a system of oversight and of regulators and of government, all of which is meant to ensure that a good standard of care is provided, had failed. And my recommendation was that the second inquiry should look at that, and in doing so, it unhappily, at least I concluded at the end of that the system had failed to spot a really gross scandal of appalling care and suffering. Well, appalling suffering because of bad care.
Obviously, we know some individuals have moved job or disappeared from the system to some extent, and there are obviously, I know some doctors who are being required to go up to the GMC to answer for their actions during this whole episode. But there is a sense, I think, out there that not a lot of people have actually had to stand up as individuals and say, you know, we failed. And that may be the right thing, but do you feel there should have been more individual accountability for what happened?
Well, one of the things I found was that our system is rather lacking in accountability, particularly amongst directors and senior leaders, whereas there is an easier line of accountability available for doctors and nurses, which of course is unfair, particularly as in many cases it would be the managerial leaders who are responsible for some of the things that occurred. So I have made recommendations which should mean there is greater accountability in the future. But insofar as what you're talking about, the people who were involved in the Mid-Staffordshire affair, I think the difficulty, if you get to the system outside the trust, is that really what we're talking about is was a systemic culture in which responsibilities always seem to be assumed to be someone else's, in which poor standards perhaps were tolerated, in which targets ruled over the priorities that should be given to patients, things like that. Well, the result is that really it was a group matter. It would be quite difficult to pin all that down to a few individuals, and possibly unfair to do so. But I think that's far from saying that people who were involved should not feel accountable and should not show that accountability by demonstrating their awareness that changes need to be made, and they need to be made now.
And when one talks about a cultural problem, I mean, we have that, both the blessing and the difficulty, that we talk about the NHS as this enormous monolith. It's interesting the extent to which we're talking about a microculture around this particular hospital and hospital trust and the surrounding areas, or the extent to which these issues can be said to exist right across the NHS. And your views on that?
Well, my job was to look at what happened in a particular trust and about a particular trust, and therefore I did not specifically receive evidence about what was happening in other parts of the National Health Service. I was asked by aggrieved people on an unfortunately regular basis to extend my inquiry to look into other things, but that was not within my power. I think all I could say on the basis of the inquiry is that the system cannot, as it exists at the moment, can't guarantee that there is not a Stafford somewhere else. And it is quite likely that there are bits of Stafford in a number of different places, and I think that's now widely accepted.
It was to some extent data about death rates that led to a concrete matter of an inquiry, but I mean there were many patient concerns and relative concerns prior to that that contributed, I think, to a picture that meant people moved to look into it. But what is your view about that as an alerting system? That you know, is it a good enough system? How flawed are the current systems for alerting to a possible Mid-Staffordshire happening elsewhere?
I don't think the systems are sophisticated enough, if one can put it that way. The mortality rates, the HSMR or the new SHMI, whatever the acronym is, can only be a bit of a smoke signal that there's something to look into, because it doesn't tell you whether individuals have died for any particular reason. It just tells you that something unexpected is likely to be happening, and one of the things, therefore, that could be happening is that a poor standard of care is being delivered. But the only way of finding out whether that is the case is actually to go and have a look.
Now, we recently had, just a week or so ago, this concern about children's heart surgery in Leeds,
yes.
After which surgery was suspended for a few days while there was a greater look. What do you feel the Mid-Staff's inquiry did to contribute to that happening? Do you feel there was a link in some way between those two events?
Well, I'm speaking personally and only on the basis of what I read in newspapers or your journal. I was encouraged by the action that was taken. It seemed to me that information had come to light which suggested there might be cause for concern, and if that was correct, then patients were potentially being put at risk, and therefore the right thing to do was to protect patients by pausing and looking to see what that information actually meant. And as I understand it, that's what has happened. So I find that encouraging, and it's taking an appropriate reaction, it seems to be, towards risk. That's not saying the information was necessarily right, but what I've said is that you wouldn't really want a pilot to take off a plane told that there might be a bolt loose in the engine without someone going to have a look to see if it was. Yes.
And do you think the public, I mean, from what you've seen and read and spoken to people, accept that? Do you think it will increase confidence in the health system if more of that happens, or do you think we might see an erosion of confidence?
Well,
if every flight you got on, the pilot said, you know, we're going to do this before we take off, you might get an erosion of public confidence.
Well, I've recommended in my report that there should be a far more transparency and openness within the NHS with the public about things that are of concern. And I think there's a learning process to be gone through, which is to increase the understanding of the public, and dare I say it, of politicians, that undertaking these processes actually protects patients rather than the opposite. And therefore the reactions that some people have exhibited of severe criticism, in fact, of this sort of approach might go away. I think it's a matter of making people understand that precautionary steps are sometimes a very good thing.
I tweeted to my few followers that I was going to be interviewing you. And a couple of questions I thought I'd bring out from that. One is, someone asked how to establish kindness as an essential value in healthcare, following what you've learnt from mid-staffs.
Well, I'd like to think that most people who go into healthcare as a profession do so in part at least because it's a vocation, because they actually want to help patients. And one would like to think, therefore, most people were naturally kind. I think there can be challenges to actually exhibiting kindness and compassion and understanding to patients because of the pressures of the job. And so I think that we need to think a little bit about how we release that pressure. I don't think it necessarily means more staff, but how you deliver that manner to people while at the same time dealing with their illness. And I think one tip might be that every patient is a human being with their problems and is not just a problem. The doctors or nurses, they come along and they treat a problem. It's feeding a patient, or they've got to examine a knee, and they don't actually realise it's Mrs. Smith they're talking to, and just a tiny little bit of conversation can re-engage with the patient as a human being, and I suspect would lead to better care and safer care because you then find out things you wouldn't otherwise find out, as an example. Without
excusing what in many cases seemed like inexcusable lack of humanity in the cases you heard. Obviously, pressure on time and working conditions and pressure to deliver can erode not only the sheer time available to have that kind of conversation, but actually one's sort of ability to engage in it too. Do you see that as a big contributor here?
It clearly was a contributor, and it's something that can happen without anyone noticing because it happens gradually. So there wasn't in Mid-Staffordshire a sudden huge decrease in staff, but over a period of time from quite a low staff base, the staff continued to be reduced. And that clearly put pressures on staff they eventually couldn't tolerate. And one of the reactions to that is that people switch off. They cannot face the reality of what's going on, so they ignore it. And I'm sure that's a reason why some nurses behaved in a way which was clearly inexcusable. Others ignored what was going on, and doctors, I'm afraid, on what must have been frequent occasions, walked by without looking.
I want to pick up on both those sides, the nursing and the doctors. To begin with the doctors, to some extent they have, although there are individuals who've been referred up to the GMC, as a body, it seems to me that the doctors may have got off a bit lightly. I don't know whether you feel the same. In terms of the GPs continuing to refer, not necessarily alerting to problems that arose, and obviously those within the hospital as well.
Well, I don't think they got off lightly in my report. Of course, I can't talk of it in relation to the reaction to that report. You've mentioned the general practitioners who, it appeared, were aware of problems and concerns, some of which were serious, and particularly when put together, but actually only thought to tell the Primary Care Trust when the balloon had already gone up and they were specifically asked. And there's some lessons to be learnt there, I think, about the system. Well, it's more, I think, about the general practitioners, the systemic collection of their information, and all the time thinking about what the information they're getting means for their patients generally. But then within the hospital, there were concerns raised by consultants about staffing and about ward reconfigurations, but they never saw those through. They eventually shrugged their shoulders because I suspect they weren't getting a hearing from management, and then went back into a sort of notional bunker and got on doing their job. Neither of those approaches actually leaves very much credit on them as professionals, I'm afraid. But I suspect that many professionals would behave in the same way. So one needs to change the culture to ensure that they are more fully engaged and listened to in relation to the business, which obviously they know more about, frankly, than a lot of hospital managers. And amongst your recommendations, the one that one of several that I found resonated strongly with me was the request that there should be a named consultant, a named doctor in charge of a patient's care. Do you think that will, if implemented, would make a significant difference to that sense that the patient has someone who's
their advocate, if you like, within the system?
Well, I find it incomprehensible, and I speak as a patient and as a visitor of patients, that you don't know from day to day who it is who's in charge of your case, whether it be a doctor or a nurse. And the old-fashioned idea of a name being above the bed seems to be a very visible form of accountability and responsibility. And in days when teamwork is very important, we still need people who lead those teams and who are responsible for ensuring you're getting the right level of care. And I think we've moved too far towards the doctor turning up, dealing with the problem and going away. And if that means that the doctor feels he or she is not responsible for getting someone to clean the patient or the bed when the patient or the bed is filthy, then we're in a very sad place indeed.
And I expect there'll be doctors listening to this who'll say, well, I would very happily take on that accountability, but actually I don't have any aegis, I don't have any control over which junior doctors are caring for my patient or which nursing staff are doing so. So there has been an erosion of that. I mean, without wanting to present it as a rosy past, there was a firm system where a senior consultant had their team under them. That largely no longer exists.
Yeah. Well, I don't think having this responsibility necessarily means you have to return to a hierarchical team with a sort of fearsome consultant ruling by fear. I mean, teamwork can be by agreement, and the fact there are many people responsible for doing things doesn't mean that there shouldn't be someone who, on a day-to-day basis, is coordinating that. And I don't think it's for me to prescribe systems in which that can be done, because I think it can be done in different ways. But all I'm saying is, from a patient's point of view, there ought to be one person, one doctor, one nurse, who at any given time the patient and their relatives know is the person who's coordinating things.
We just had a session here at the Quality Forum from the Netherlands about patient partnership, and the recommendation of having a chief listening officer, which I thought was rather good.
Yeah.
And the profile of the person was probably from a nursing background, who had as their sole job at any one time to listen to the patient and the relatives. I mean, can you imagine that being there's obviously resource implications, but would that...
I think I wasn't there, but it sounds like a very interesting idea. But we might come to inspections later and the chief inspector, but perhaps a danger if you have a chief listening officer that
nobody else
does listening, it is really absolutely everyone's job, from the maintenance man, the cleaner, anyone who's going past the bed. Actually, his job is to listen to patients, because after all, that's why the hospital service is there. So I think we've got to get over a message that everyone needs to listen, but if that takes a chief listening officer, well, fantastic.
Onto the nursing side, amongst your recommendations is one that hospitals should establish, or there should be a minimum staffing level. In the government's initial response to your report, that has not been taken up. I mean, I know there was a large number of recommendations, and what do you feel about that? They're kind of saying that should be done, I think, at a more local level, and hospitals should be given outcomes, you know, in terms of quality, and they must then decide whether a minimum staffing level.
Well, I'm not sure that the government's response has rejected the essence of what I was getting at. I mean, I didn't think that some national percentage minimum figure of how, or ratio of nurses to patients would necessarily help, and I rejected that as something I wanted to recommend. But what I did recommend was that we needed to have evidence-based guidance which was specific to particular activities or services, and I suggested it should be produced by NICE, which would give guidance as to the number of nurses you need to deal with any given situation, and that if that wasn't being followed at any given place, it wouldn't necessarily be a breach of a standard, but it would give rise to questions being asked as to how the place was delivering a satisfactory care without it. So I'm not sure that the government's necessarily rejected that as a concept yet.
It may be too early to say, but do you have what are your thoughts on the government's initial response? I mean, they've done things that you didn't recommend, and they haven't initially indicated they're going to do things you have recommended.
Well, the one thing I'm sure we're all agreed on is that what needs to be sorted out is very complicated. We're dealing with a very complicated system. In the past, that has led to a reaction of, well, it's just too difficult, I think, and therefore ignore it. And we've now moved to a stage where it's recognised that something needs to be done. And my recipe involved 290 recommendations. So I'm not surprised that no clear answer has come up with regard to those yet. What I would clearly be concerned about, but I don't think we've got there yet, is that after months of people talking very enthusiastically about things, the momentum just fades away and we end up where we were before. I don't think we're there yet, but I'd like to think I might keep an eye on whether that does happen.
Yes, I mean the thing people are talking about a lot is the Bristol Inquiry back in the 200s. 12 years on from then, I think it's 12 years. I mean, I've got that wrong.
Yes.
12 years on from Bristol. The big message that people seem to remember from Bristol, there were many recommendations, as in your report, is the one about data, that there should be much greater availability of outcome data, in particular mortality data. And as we know at the moment, those data only really exist in child heart surgery, or in heart surgery generally, and that the vast swathes of healthcare, we don't have that transparency over data. I know that things are happening, but there is that 12-year gap even to where we are now. If in 12 years' time things haven't been picked up from the work that you've done and from the tragedy at Mid-Staffs, what do you think will be the one thing we'll be saying, that was the thing we said we would do and we haven't done it, if you see what I mean? And what's the one, listening to patients you've mentioned, is that what's the concrete thing that we absolutely have to say to the government, you must do it now?
Well, you say the government, you must do it now.
Yes, sorry.
And actually, I think there's a lot that doesn't need to wait. I'm afraid part of the culture of the health service has been a little bit waiting to be told by the government what to do. And actually, a lot about information doesn't require government action. I mean, it would help, perhaps, but I think it's the duty of all professionals, whether they be doctors or nurses, whether they be individuals or specialties or colleges, to contribute to the provision of information upon which we, the patients, we, the public, can judge whether they're being effective. Whether they can judge whether they themselves are being effective. And to say, oh, it's too difficult, is really to bring into question, it seems to me, the validity of what they're doing at all. So I think it's absolutely essential, and maybe Sir Ian Kennedy said it, but let me say it again. It's absolutely essential that we work in all medical disciplines and clinical services towards measurements of whether what is happening is effective, whether it's safe, and most importantly, whether it's what the patients want. And if it isn't, if we don't get that, then we will have no real driver towards improvement and towards maintaining even minimum standards, in fact.
Just to pick up on that, I absolutely agree, you're right, it's not the government, and in the case of Bristol it was the heart surgeons who got their act together under some pressure from Freedom of Information Acts, but they did do it, and to be commended for that. But I wondered
But even they would say they've got some way to go.
A huge way to go. And there was a piece in the BMJ just recently describing the problems, because the complexity is there, and bringing their colleagues along. One of the issues that I was interested to see was the question of resource, though. I mean, if the government wants to facilitate this, it's obviously others' responsibility necessarily to maybe do the work. But is there a resource implication in actually providing, I don't know, skills and technology to help these data become more transparently available?
People always say that, and I'm sure there is a resource implication, but I suspect a lot of it is actually resource reallocation. I mean, if one takes it at its most basic level, the information about how effective treatment of an individual patient has been should already be in some shape or form in their records. A surgeon should already be keeping records of how effective what he's doing is, because particularly now through revalidation and so on. A hospital trust should be keeping some form of information going about the comparative performance of different wards, about infection rates and so on. And I think that, so I think the basic material is there. It's a question of how it's organised. And I suspect that the only way it's going to be driven into being really useful is again to make as much public as possible, and I believe a lot more can be made public, and I think there's general agreement about that, even if there are problems with it. And I think there's this fear that we can't trust the public with information because there are issues about its reliability. It seems to be that to get better and more reliable information, we're going to have to put this stuff out there and then explain why it's unreliable, and then the public and everyone else can actually perhaps contribute to making it more reliable. And we live now in an age where there's an assumption that information will be freely available, so other people other than the chosen few can analyse it. And I think if we allowed that to happen, we'd actually find some answers to some of these more difficult problems about what is the way to measure things rather more quickly. I mean, after all, Dr. Foster was in effect a private initiative, and as you say, after a battle with freedom of information and so on, got hold of the data. And while no one would say what they produce is perfect, it's a lot more informative for the public than anything that went before.
The government's announced various additional inspection regimes, largely a new hospital inspectorate. Yes. And also we have Healthwatch, which is a patient consumer side of things. Can you give your thoughts on those? What will contribute to their likely success?
Well, so far as inspection is concerned, I recommended that the Care Quality Commission should consider very carefully returning to a model of what I call more professionalised inspection rather than generic inspectors. I believe that's what they intend to do. And I didn't recommend a chief inspector, but the idea of a chief inspector who could lead such a team seems to me to be very welcome. Of course, the idea of the chief inspector also comes with a government proposal for an Ofsted-style rating, which he or she would be responsible for. And that wasn't part of my recommendations, but that doesn't necessarily mean I'm against it, so long as we don't ignore the really important need to be looking for poor practice in particular parts of a hospital, and so long as an overall rating doesn't disguise that poor practice in any way.
An overall rating does seem quite ambitious. I mean, the lack of kind of granularity of that seems, for a large hospital covering vast numbers of different types of treatment and different skill sets, seems I would say unwise. But
well, I think the detail of that probably needs to be worked out. And I noticed the Government Commission report from the Nuffield Trust had quite a lot to say, and I think the basic message of that was it can be done, but an firm eye has to be kept on the danger of disguising poor practice in part. And the reality is, even in Stafford, the poor care was not to be found absolutely everywhere. There were some areas of really good practice in Stafford. So these
which may have contributed to patients' loyalty to the hospital to some extent. So you got that kind of mixed message. I don't know if that. Well, certainly in Leeds, there was a terrific sense of patient loyalty.
Well, patients will, to some extent, and there's nothing wrong with this, will to some extent be influenced in their opinion by the outcome in their particular case. And even in places that are poor performing, it will only be a minority, happily, who suffer from poor care. But too much comfort has been taken in the past from figures that suggest the majority of people have got away without being harmed, by way of example, when actually the emphasis should be on it being totally unacceptable that anyone is harmed.
And getting back, as we finish now, toward the patient experience, how confident are you that these new approaches to gathering and collating patient experience will make a difference?
Well, I think progress is being made, and obviously different methods the different methods being used need to be kept under review. The one thing I'd like to see more of is we talk a lot about real-time feedback and so on, and I think that's absolutely great. But we do, I think, need to have more information taken from patients a little while after they've left hospital. Because I think people and even their relatives are afraid sometimes, quite often, to speak up in hospital about concerns because they're afraid of the consequences. Whereas if they got home, and you need a conversation also with people, because we'll often start off a conversation, I have found, with saying they had wonderful care. They tell you about the positives, but it's only after about a couple of minutes they tell you about some of the more concerning negative things. And I think somehow we need to capture that in the feedback we get from patients.
What's the most difficult question you've been asked since your report was published?
Well, as you know, I've been giving quite a few talks up and down the country, and I had a discussion with a very promising, inspiring group of medical trainees, and who were looking at how they could help in the change of culture that's needed. And the one question I was asked, which was challenging, was from a young man who said that a few days before he'd been holding the hand of a patient at 3 o'clock in the morning in a hospital where he wasn't terribly happy with what was going on. That was the doctor. And the patient asked him, would he be happy for his relatives to be treated in this hospital? And he wanted to know what I thought the answer to that question should be. And I didn't immediately answer that, and we had a discussion around the room about it. And one interesting answer came back, which was, well, from a colleague of his was, well, of course you reassure the patient with whatever it is, in any way you like at that point. But you do two things. Firstly, you try to explore what it is that's really worrying the patient. But secondly, what are you doing about your own feelings? What are you doing the following morning about those feelings? Who are you going to share that concern with? Which, of course, didn't answer this poor man's question either. And my eventual suggestion of an answer was that he should say, well, if his parents came into the hospital, of course he'd make sure they got the best possible care, and that he as an individual would be making sure, as best as he could, that this patient would get that care as well, and as it were, to convey to the patient his own professional responsibility towards that patient to do the best he could for him. And it's a slight cop-out, but that's what I thought the answer should be.
Robert Francis, thank you very much indeed for talking to us.
It's a pleasure.